First, a general definition of viral hepatitis. Hepatitis can be defined as inflammation of the liver resulting in altered function. It can develop into either an acute or chronic infection and has a high risk of developing into cirrhosis and liver cancer. Now, the etiology. I will now discuss the pathophysiology. HBV has an outer capsule of HBsAg, an inner core of HBcAg, and some HBeAg. Mature HBV virions first enter hepatocyte through the cell membrane. The exact mechanism is unknown, but it may be via a sodium taurocholate carrier-transporting receptor, endocytosis, or a direct fusion to the plasma membrane. After uncoating and released to the cytoplasm, the nucleocapsid is transported to the nucleus, where the double-stranded relaxed circular DNA is repaired to form closed circular DNA, which is crucial for the survival of HBV, where then transcription and translation takes place to form viral proteins, and thus replicate HBV and increase viral load in infection. Through exposure to viral nucleic acids, proteins, or tissue damage, the body initiates a cell-mediated immune response. The larger it is, the greater the chance of fighting the virus. While this immune response is important, it's also key in causing liver damage, particularly through the cytotoxic T cells, inflammation, lack of HBV-specific antibodies, and harmful effects of HBcAg from HBV. The liver is normally responsible for many vital roles such as blood homeostasis, metabolism, detoxification, and immunity to infection, through the secretion of proteins such as bactericidal proteins, opsonins that assist in phagocytosis, clotting factor fibrinogen, and more. Its primary functional cell is the hepatocyte, which responds to inflammatory signals by releasing such proteins to form chemical cascades that lyse infected host cells. The earliest non-specific response involves the release of inflammatory cytokines such as interferon alpha, which activates extrahepatic leukocytes that team up with Kupffer cells in the liver to have phagocytotic roles in processing the HBV and presenting them to T cells. This action releases chemical signals that cause stellate cells to begin depositing collagen in the extracellular matrix in an attempt to limit the spread of infection to other cells as scar tissue. Normally in healing, the collagen matrix dissolves and the activated stellate cells die off. However, in HBV, the collagen matrix increases too rapidly and cannot be dissolved, building up scar tissue and cutting off access to blood, oxygen, and nutrients, killing liver cells. A vicious circle of inflammation and fibrosis stimulate each other, worsening the liver's condition. Additionally, natural killer cells recognize HBV as foreign and thus limit spread via antibody-dependent cell-mediated cytotoxicity. After this innate immune response, B and T cell lymphocytes, particular helper and cytotoxic T cells, recognize and kill infected hepatocytes through binding HBV envelope proteins and free particles, forming a complex and removing them from circulation. Thus, chronic infection by HBV occurs when there is a deficit in this targeted T cell response, or due to the continuous proliferation of hepatocytes, which allows HBV to escape into the blood. Another mechanism that allows HBV to survive host immunity is that it encodes a reverse transcriptase, which allows it to integrate its own DNA within the host genome, thus becoming invisible and escaping detection. Clinical signs and symptoms include loss of appetite, nausea and vomiting, fever, abdominal pain, and others include jaundice, dark urine and pale feces, joint pain and rash. And finally, epidemiology. Overall, HBV infection tends to be high in males, seen in the orange line being higher than the brown, and the most vulnerable age group was 25 to 29 years old, however has declined by 38% to be overtaken by the stable 30 to 39-year-old age group. The prevalence of HBV in Australia has increased due to migration from endemic areas. as China is the country where 40,000 Australians with HBV were born, followed by Vietnam and Philippines. Aboriginal and Torres Strait Islanders have always had higher rates of HBV infection than non-Indigenous populations, perhaps due to limited access to health services. In 2016, the rate was 31.1% in the Indigenous population, as opposed to 22.8% in the non-Indigenous group. Over time, the orange line decreases due to implementation of childhood vaccination, while the brown remains stable as it includes migrants from unvaccinated countries.